Good morning, everyone, and welcome to Pediatric Grand Rounds. It's my pleasure and honor to introduce our speaker today, Dr. Michael Georgieff. Dr. Georgieff almost needs no introduction for most of us. He's been an influential mentor and teacher to many of us here during his 36 years and counting at the University of Minnesota. Dr. Georgieff currently holds the position of the Martin Lenz Harrison Land Grant Chair in Pediatrics. He is a professor of pediatrics and developmental psychology, is the executive vice chair of the Department of Pediatrics, the director of the Center for Neurobehavioral Development, and the current co-director of the new Masonic Institute for the Developing Brain that's set to open on November 1st. Dr. Georgieff's research has truly spanned from the bench to the bedside and back again, focusing on fetal neonatal nutrition and its importance for brain development. He's been a very strong advocate for early life nutrition towards optimal child development and provides advice nationally and internationally to the American Academy of Pediatrics, the National Institutes of Health, and UNICEF, to name only a few. Today, Dr. Georgieff is going to talk to us about maybe his favorite nutrient, or at least the one he's thought the most about, iron. So I want to thank you, Michael, for taking the time to share your expertise with us today. And with that, I'll let you get started.
Thanks, Dr. Yale. Appreciate that. And it's kind of odd to go. I was the one who was supposed to be announcing the Grand Round speaker, and we had a different one. So that was going to be Dr. Rosance from Colorado, who unfortunately broke his wrist, compound fracture, bicycling. And all of you know that I like to bicycle as well. So just a warning that it's not necessarily a safe sport. Be careful out there. Yeah, so right, I'm going to talk about neonatal iron management from fetus to follow-up. And first, let me just tell you, I have no financial disclosures, nor any political ones or anything else. I'm not going to discuss any off-label use. It's kind of hard to talk about off-label use of iron, I suppose. And let's just take a look at the objectives. I want to tell you what I'm going to talk about, and I also am going to tell you what I'm not going to talk about. Iron is a huge subject, and we're not going to try and cover the whole thing in 45 minutes. So the objectives are, you probably saw in the title, we're going to talk about neonatal iron. So we're going to talk, in order to do that, you're going to need to know about the timing and the rate of fetal iron accretion, hopefully by the end of this talk, at least as far as the brain is concerned. I'm going to convince you that birth is just kind of an interesting event in there, but iron accretion and brain development just kind of march along in a time-like way from fetus through the newborn period and onward. We want to define what the maternal risks are to fetal iron accretion. I know I'm not giving obstetrics grand rounds, but I think it is important for pediatricians to realize that when you have a newborn, you are looking at an archive or kind of an archaeological dig into what came before. It's important to know what our status is at the time of birth as we start to take care of the kids afterwards. Then we're going to talk about kind of the stressors on the iron balance in preterm, mostly in preterm infants in the hospital, so specifically in the NICU. And there are a fair amount of controversial areas about the iron requirements of the preterm infant. And I know when I'm on rounds, or when I teach the residents in morning teaching on the NICU, there's always lots of questions around the confusion of how much iron are we supposed to be giving these kids. And then probably more importantly, defining the postnatal iron requirements, because whatever happens in the NICU carries forward into the discharge period. So we're going to talk about that as well. And what I'm not going to talk about, when anybody sees the title iron deficiency, I think most people would think about classic toddler iron deficiency, the one that we all learn about in medical school. And we're not going to talk about that and its neurobehavioral issues, except as they link to neonatal iron deficiency. So there's been a paradigm shift in the way we think about postnatal iron deficiency and neonatal iron deficiency. And that is and I'll explain this later, that the two of them are actually linked. And then the third peak of iron deficiency in pediatric practice is in teenage girls. We're not going to talk about that either. We're also not going to talk about all the other consequences of iron deficiency beyond the brain. This is really a talk about brain development and the role of nutrients in brain development, and specifically iron. Iron is one of the most studied nutrients, so there's a lot to be kind of taken away from that perspective. I'm not going to talk about iron deficiency anemia, how you diagnose it, its effects on the immune system, T cell function and so on, nor on a rather interesting area that is developing about the effect of both iron deficiency anemia as well as iron supplementation on the gut microbiome. We can maybe talk about that a little bit in the question and answer period. I'm also not going to be sharing all the fundamental neurobiology that our lab in neonatology has been doing. It's just great work by Raghu Rao and Tommy Bastian and Futran and Tate Gislin. There's just a whole bunch of us that work in this space, and they've really elucidated a lot of the mechanisms by which iron regulates brain development. We just simply don't have the time to go into that. So this is mostly a clinical talk. I will get into why iron is important, and we'll just start with that it's just basically a critical nutrient for the developing neonate and specifically the brain. It's found in what are called iron cluster. Iron is often found with sulfur in enzymatic pockets of enzymes like hydroxylases, and of course the better recognized hemoproteins like hemoglobin, myoglobin, and cytochromes. So it's important for tissue oxygen delivery, and it's involved in brain development and function through by influencing structures and regions and processes that make your brain basically go and function efficiently. So that includes desaturases that are involved in the synthesis of fatty acids for myelin. So it's going to have an effect on speed of processing of the brain. Obviously, the role of cytochromes is to mediate electron transport, generate ATP. The brain is a very greedy organ during the neonatal period. It takes literally 60% of the total body oxygen consumption. So if you think about how many calories you give a baby, 100 to 120 calories per kilo, 60% of that is going up to the brain to help its structural development. That's kind of the cost of growth of a rapidly growing system. And then probably the oldest literature actually is that iron is involved in the synthesis of the monoamine neurotransmitters, so dopamine and serotonin and norepinephrine, as well as influencing glutamate metabolism. So it has an effect on how the brain functions from a neurotransmitter standpoint. It also regulates growth factor synthesis, and what mostly Futran has discovered is it regulates gene expression through epigenetic modification. So that's your neurobiology for the day. We're going to do a little bit of animal modeling in the middle of the talk, but those are the reasons your brain needs iron. It is one of the most studied nutrients out there, and so it really is a good medium to work in to see how nutrients interact with the developing brain. We're going to return to this slide several times here. And this slide is from an article by my old collaborator, Chuck Nelson. And it basically just shows you a map of brain development across the lifespan. And the first thing you're going to notice is if we're talking about brain development, most of it is happening by about the age of 3. All right. So if you ever wondered about why our public policy is focused on 0 to 3, or now we talk about the first 1,000 days, which is from conception to about 2 years, this is why. All of that brain development is taking place, myelination starting at a couple months prior to term birth, synaptogenesis, your ability to start hooking up your brain, circuit building, happening at least 3 months prior to term. 3 months actually comes from the hippocampus. Rapid hippocampal development starting at about 28 weeks gestation. So yes, our preemies do have memory formation of what we are doing to them in the NICU, and so on. And you can kind of see these are just waves of activity. The visual cortex and the auditory cortex starting to develop even prior to birth. We know that fetuses can hear and preterm babies can hear. And then the language peak a little bit later in the second half of the first year. And even higher cognitive processes, prefrontal functions that we think about in more complex behaviors like executive function and attention and inhibition and multitasking, even that is ramping up, starting prior to birth and then during that first year. Now, if we then ask the question, what is this purple box basically shows you that this is what's happening prior to birth. If we then ask the question, what are the things that are iron dependent? I've circled them in red. So I talked to you about myelination, I talked to you about synaptogenesis, and then that rapid hippocampal development. So these are the ones that have the high requirement for iron, starting in that late third trimester and moving on into the post-term months. Now, everybody, pardon the pun, but iron is kind of a polarized field. And whereas I happen to study the effects of iron deficiency and the need for iron, one has to recognize that iron is also a potential risk and that there are oxidant diseases that are probably related to iron overload. It reacts with oxygen in the Fenton reaction to create reactive oxygen species. And in fact, in the adult literature, brain literature, there's plenty of examples of iron overload being associated with neurodegenerative disorders. For example, status post-acute hypoxic ischemic injury like a stroke, or in the etiology of Parkinson's and Alzheimer's. In theory, our fetuses and our premature infants in the NICU should be at high risk for this potential iron toxicity. Now remember, iron toxicity is only going to happen when you have free iron, that is non-protein bound iron. As long as iron is bound to transferrin, it is essentially hidden. It's a kind of a neat molecule because the iron is actually hidden inside the transferrin molecule. It doesn't really pose any risk. But if it's free iron, it overwhelms the iron binding capacity, say after you have a lot of hemolysis or you give a big dose of IV iron, then there is the risk for iron toxicity. Fetuses and premature infants have underdeveloped antioxidant systems to fight that. They have low protein levels and therefore a low total iron binding capacity, so a bigger chance of overwhelming the iron binding capacity with iron dosing. And it's been proposed that it has a potential role in what are termed oxidative diseases that we treat in the NICU, like retinopathy of prematurity, bronchopulmonary dysplasia, and necrotizing enterocolitis. To be fair, I have to say that relationship to iron actually has more to do with transfusions and iron overload from transfusion as opposed to dietary iron. But you'll see articles, continuing to try to link the dosing of iron enterally, in other words, just nutritional management of iron, to these diseases. So stay tuned for that. You probably all learned that all nutrients are important for the body in terms of cellular function. It's certainly true for the brain, and that they all, or most of them, display what's called a U-shaped nutrition risk curve. So your range of adequacy is your most efficacious dose of a nutrient, and is also typically your lowest risk. And I think most of us concentrate on this side, which is your risk of problems. Let's say neurodevelopmental issues, increases as you head into a deficiency state, right? So iron deficiency or protein deficiency or iodine deficiency, they're all going to increase the risk to the developing brain. You also need to recognize that overload can do the same thing, that if some is good, more isn't necessarily better, and that there are risks to having too much of a nutrient. If you look at iron, which is here in purple, you can see that it is a riskier compound, if you will. The range of adequacy is smaller, and the risks from deficiency and overload appear to be greater than maybe some of the other nutrients that are out there. So iron has been referred to as the bad boy of nutrition. Well, why do we worry about it? Because there are 2 billion people that are iron deficient around the world. So there's about 7.5 billion of us. And it has a particular tropism for the population that you and I are interested in, which is pregnant women, their fetuses, and then their offspring. And that's why it's important that we've now linked neonatal iron deficiency or iron deficiency during pregnancy with postnatal iron deficiency and long-term neurodevelopmental issues. And I'll get to that in more detail. Every cell, every organ system needs iron. Anything that's making ATP, anything that's got an electron transport chain and it needs cytochrome and requires adequate cytochrome function needs iron. I think it's important to recognize that iron deficiency anemia obviously has clinical symptoms. You feel tired, you're not as smart. Most people think that's due to anemia. That's a common thinking in adult medicine. And because of that, they think, well, what's the big deal? You give them some iron back, or you give them, or you transfuse them, symptoms get better, problem solved. In fact, that problem is not solved in a developing creature like our kids, because there are long-term issues involved from the tissue level iron deficiency that also occurs. So I think all of you know that anemia is the end stage of iron deficiency. The body is set up by currently unknown mechanisms to prioritize iron into the red blood cells and away, or not away, but in preference to all the other organs, including the brain. And the brain is prioritized over the heart is prioritized over skeletal muscle. So situations where you have already gotten to anemia, you can assume that you have tissue level iron deficiency. And the problem with that in the developing brain is that while some of the effects of tissue level iron deficiency, like cognitive and motor deficits, are temporary while you're iron deficient, others remain long-term, even after you've repleted iron. So basically, horses out of the barn at that point. Don't go there in the first place. Prevention is worth, an ounce of prevention worth a pound of cure. So iron really follows that kind of mantra. One of my favorite quotes is that eradicating the world's iron, zinc, and iodine deficiencies, those are the three most common micronutrient deficiencies, would raise the population IQ by 10 points. And unfortunately, one of the problems of doing grand rounds by Zoom is I can't take a poll now to raise your hands. I suppose I could through the chat, but raise your hands for who would like an extra 10 IQ points today as you go on rounds. So let's walk our way now through fetal iron deficiency, then iron status in the NICU, and then finally postnatal iron deficiency. The first thing you need to know is that pregnancy is an impending iron deficiency state. First of all, up to 42% of women in the US, up to 80% internationally, have marginal iron status entering into pregnancy. And then pregnancy imposes a tremendous stress on the maternal iron axis, because the mom expands her own blood volume, because the placenta, which is a very metabolically active organ, has a high demand. And then, of course, you've got the fetus on the end of the whole thing, who has a iron demand for blood expansion, for organ growth, including the brain, and also for storage. So this is an important point. All mammals, humans in particular, are born with large iron stores, much greater stores than per body weight than, let's say, we keep as adults or even older kids have. And that storage kind of teleologically has been proposed as a way to compensate or to help the baby postnatally because of the iron demands of growth when they are on a low iron diet, which breast milk is. So basically that storage is there to have the baby have adequate iron for the first 4 to 6 postnatal months. The fetus basically keeps about 75 milligrams of elemental iron per kilo body weight during that 3rd trimester. So if you take a 500 grammer at 24 weeks, they're going to have about 37 plus milligrams of iron if they are appropriately loaded. Whereas that term baby, who's over 3 kilos, is going to have over 225 milligrams of iron. So you can see there's a lot of accretion in that last trimester. And so maternal dietary iron restriction could have a pretty profound influence on the fetus, although the fetus is actually a pretty good parasite. The placental mechanisms are such that it favors fetal transport. Like in us, the majority is found in red cells. And then I told you about those large, mostly liver, but basically in the reticular endothelial system storage pools. And that's reflected by your ferritin, right? So your red cell iron is going to be reflected by your hemoglobin. You can do the calculations to figure out how much iron there is in the red cell mass if you know the hemoglobin, because it's about 3.5 milligrams of iron per gram of hemoglobin. We have nomograms for ferritin and liver iron stores, so we can figure out from the newborn ferritin how much liver iron is there. And that accounts for almost 90% of the total body iron. What those biomarkers do not account for is the non-storage tissues, meaning the brain, the heart, the skeletal muscle, which accounts for the rest. And we're desperately in need of biomarkers of what is the iron status of, let's say, the brain or the heart or the skeletal muscle, because remember, anemia is the final stage. And to be honest, there is no physiologic consequence of just having low stores. So having a low ferritin per se probably doesn't do anything. It just reflects that you don't have any more iron to give these non-storage tissues. So Raghu Rao has a huge NIH grant to look at this question of what are some biomarkers that can be measured peripherally, meaning in your bloodstream or other body fluid, that reflect what's going on in the brain. And as I said, if you take nothing home from this entire talk physiologically, just realize that fetal and neonatal iron is prioritized to red cells over the brain. And what that means is that non-anemic infants and newborns can be brain iron deficient. In the newborn population, and I'll show you the outcome data on this, it can be detected by low iron stores. That is, once your ferritin drops below the 25th percentile, which is 76 micrograms per liter, the liver can, or the stores can no longer provide adequate iron for brain needs, and you start to see neurologic symptoms. And these, we'll talk about it, but the neurologic symptoms can be found in any of the domains that I talked about on that second slide of what iron does for the brain. So myelination, synaptogenesis, and monoamine neurotransmitters. We have come to learn, when I first entered this field, and maybe perhaps it's still taught, that when you think about your classic pediatric patient, your 10-month-old or 12-month-old or 15-month-old with iron deficiency, that's just due to lack of adequate iron intake postnatally, and combined often with, especially internationally, with intestinal blood loss. So that would put you into negative iron balance. And while that is a true pathophysiology, people fail to recognize that much of that was set on, well, that also depends on how much the baby started with, meaning how much was stored and whether they had an adequate hemoglobin and ferritin at birth. We've now learned that fetal iron underloading, and we'll talk here about the gestational conditions that give you that fetal iron underloading, is associated then with earlier postnatal iron deficiency. So iron deficiency in young children is due in part to the following gestational conditions: maternal iron deficiency. Now, I told you that the fetus is really a pretty good parasite. The active transport mechanisms in the placenta favor the fetus, but there's at some point where the entire maternal fetal dyad becomes deficient, and so the fetus still gets shortchanged. And that occurs when you have a mom who's got a hemoglobin, a pregnant woman who's got a hemoglobin of less than 100 or 10, if you will, and or a ferritin concentration of less than 13.6. There are other ways that a fetus can be shortchanged during gestation. One is hypertension, which is the most common cause of intrauterine growth restriction. So about 50% of IUGR babies have low ferritin levels below the 5th percentile, suggesting that they did not get their full complement of iron. That shouldn't surprise you. When you look at an IUGR baby, of course, your eye sees protein, or muscle loss of protein and fat malnutrition or undernutrition. But why wouldn't the micronutrients be affected as well? And they certainly are. Premature delivery. So I told you that you accrete iron in that last trimester. If you are, as Shakespeare said, untimely ripped from the womb, which we have a unit full of kids of, then you have not accreted your full complement of iron, and that increases your iron demand postnatally. I should point out that both IUGR and premature delivery are also risks of maternal iron deficiency, particularly in the first and second trimesters. And then there's a kind of an odd pathophysiology that I spent about 10 years trying to figure out. about why infants of diabetic mothers have exceedingly low ferritin concentrations. And part of that is that they're polycythemic, so the iron is actually shunted into the red cells. It turns out that happens at the expense of the brain because of the inability of the placenta to completely compensate for that increased iron demand. That's driven by gestational glucose intolerance and fetal hypoxia that comes with that. My point here is that all of these conditions are associated with poor neurodevelopmental outcome of the offspring. These are just some of the data that show that relationship between maternal iron status and fetal iron status. If we look over here in the upper right, you can see maternal serum ferritin plotted on the x-axis, and then the cord blood serum ferritin as a function of maternal. One thing that you notice is that ferritins are all over the board. It's a very squirrely marker, but there is certainly a break point that Betsy Lozoff's group identified at about 13.6. And now this number is now used as a treatment trigger point for giving moms more iron. The other thing is this association or this connection now between fetal iron status and postnatal iron status. If you look at the baby's iron status at 9 months of age, in the past, we would have concentrated on these two purple boxes down here. What's the baby fed? Is there postnatal iron supplementation? Is there blood loss? All of the yellow boxes show you the prenatal conditions that influence infant iron status at 9 months of age. So it looks like there's a lot of things that could be potentially manipulated to prevent iron deficiency at 9 months that are occurring prior to birth. As I said, the reason we worry about iron deficiency are the brain effects, and particularly the long-term brain effects. It's been interesting to try and figure out just how iron deficient the brain is. There are no studies of, say, toddlers, that 9-month-old with iron deficiency, or infants or toddlers. We have no idea how iron deficient their brains are. Similarly, for babies born to iron deficient anemic mothers, these kids fortunately don't die, and we don't have their brains to look at. But occasionally, growth-restricted babies and infants of diabetic mothers do die in the newborn period. And we did a couple of autopsy studies in the 90s to look at the degree of iron deficiency, just to help us in terms of knowing how to model this and what the consequences might be. And we came up with a pretty consistent number that in these newborn populations, the reduction in brain iron is somewhere in the range of 30 to 40%. So I want to show you, because a picture's worth 1,000 words, I want to show you what the effect of a 40% reduction of brain iron does this is in a mouse, and this is a non-anemic mouse. So this is not a dietary model. This is actually a genetic model that was developed in my lab by Eric Carlson to shortchange the neurons in the hippocampus, and that's what we're looking at here in these pictures, to shortchange the neurons of iron. And this results in a 40% reduction of brain iron in the hippocampus. And on the left hand of these two photomicrographs, this is high power views of the hippocampus. These are the cell bodies, the somas, and these are the dendrites that are hanging down into an area called stratum radiatum. And this is where axons from area CA3 are going to come and synapse. Why is that important? Because this is basically where memory occurs. New synaptogenesis, strengthening of those synapses that are forming down here, is in fact associated with stronger memory, learning and memory capacity. And you can see how absolutely regular and predictable the structures are. The dendrites are nice and long. They all end up in the same place. The organization of the cell bodies is very straightforward. This is your brain on 40% iron deficiency. And you can see the disorganized structures in the hippocampus. You can see the early break points and abnormal structure of the dendrites. And not surprising, and these are pictures now, I need to point out that these are pictures in adult animals who were iron deficient as pups. We devised a model where we could replete the iron, and if you did not replete it in time, you still ended up with these changes in adulthood. Not surprisingly, these adult animals perform very poorly on learning and memory tasks like the Morris water maze. So just keep that in mind when you see those iron deficient kids, that their brains might look something like that. You can kind of group the neurodevelopmental consequences of fetal iron underloading into really three categories. The first is acute, right? So you've got an iron deficient brain, you're going to have abnormal neonatal brain function. If I make you guys iron deficient, in fact, you will also have abnormal brain function. In the case of the neonate, they have poor recognition memory. Asha Siddhapa in our group first demonstrated that back in 2004, and Betsy Lozoff's group has demonstrated it in that China study that I showed you the data from. And that's thought to be abnormalities in the hippocampus, much like I showed you on the previous slide. Sanjeev Amin is a neonatologist. I think he's at New Mexico now. Originally was at Rochester. Showed that babies with low ferritins, preterm babies with low ferritins at 36 weeks post-conceptional age have slower speed of neural processing. How do you do that? You do that with simple tests, auditory brainstem evoked responses, and you look at the latencies. And then Ted Wax, looking at term infants in Jamaica, where moms had a high incidence of iron deficiency, as did their babies. There was very poor maternal-child interaction. Basically, moms and babies kind of ignored each other. And we think that's the dopamine effect. So you can see the structural effect, the myelin effect, and then the dopamine effect. What's more concerning are the long-term mental health abnormalities that are associated with fetal iron deficiency. And they range, not surprisingly, based on when the iron deficiency occurs. So if you have iron deficiency in the periconceptional period or in the first trimester, there is an increased risk of autism in the offspring. If it's in the second trimester, there's an increased risk of schizophrenia. And if it's in the third trimester, much of what we've been talking about and what you need to think about in our preterm infants, because essentially they're exteriorized third trimester fetuses, you see mostly neurocognitive effects. And then finally, the third consequence, the baby may be iron sufficient at birth, but born with lower stores, so not showing any acute symptoms, but they are more likely to develop postnatal iron deficiency. And this is particularly true in the preterm babies and the IUGRs. And that will influence how we think about how we dose these kids at the time of discharge. And that's toward the end of the talk. Postnatal ID, as I said, I'm not going to talk about it. It's a huge literature, but there are over 40 studies that demonstrate the acute and long-term neurobehavioral abnormalities that include motor dysfunction, socioaffective problems, increased risk of depression and anxiety. And this is really your cost to society of early life. Iron deficiency, or for that matter, any nutrient deficiency in those first 1,000 days, is the loss of job potential, the increased risk of mental health problems, the loss of educational potential. And that can be quantified. There are studies of iron supplementation and whether prenatal iron supplementation is a good thing or not. There's a lot of debate about that because iron supplementation of iron sufficient women may have some risks to it. The World Health Organization and other groups would love to have a one size fits all. Unfortunately, biology is a little more complex than that. But prenatal iron supplementation, if you are at high risk of iron deficiency, improves pregnancy outcome, meaning I told you that iron deficiency increases the risk of low birth weight, either IUGR or prematurity. In fact, prenatal iron treatment reduces that rate, so that's good. And prenatal iron supplementation in and of itself improves neurocognitive outcomes at school age. And so this is work done by Perul Christian. On the other hand, postnatal iron supplementation routinely in risk populations does improve hematology. And so Santa Pasricha has a paper just came out in New England Journal that shows that yes, postnatal iron supplementation starting at 8 months or randomizing kids to higher versus lower dose at 8 months of age improves your hematology. And we're all happy for that. But it has a very variable effect as you look across the literature on neurodevelopment. For example, Pasricha didn't find any effect on neurodevelopment, nor did Perul Christian actually when she then supplemented the kids in the postnatal period. On the other hand, Betsy Lozoff's work shows a strong positive effect if you are giving the iron to an iron deficient population. She also, however, has shown that if you supplement pretty heavily, iron sufficient or overloaded populations, there's actually a negative effect. In other words, poor developmental outcome at 10 and 16 years. So it demonstrates that there's a difference between fetal and postnatal iron effects, and that in fact you get much more bang for the buck with fetal iron loading than with trying to chase it postnatally. And by the way, the literature on docosahexaenoic acid, so the fish oils, looks very similar. Very little effect of postnatal DHA supplementation. So kids aren't necessarily needing to take fish oils, but supplementation of the mom has long-term effects on the offspring. All right, how about during hospitalization? Well, that is about the wildest time in iron balance for any population. First of all, babies are born with a highly variable amount of iron stores. This is from another paper from our lab, again by Asha Siddhapa and Rao, showing by gestational age, the range of ferritin concentrations. What's the bottom line? The bottom line is that the average ferritin for a term infant is about 134, and for a preterm infant is around 115. And there are your fifth percentiles around 40 and 35. I think it's notable, and something that you're going to see more in the nutrition field. When we talk about a deficiency, we're typically talking about population norms. Your hemoglobin is below the fifth percentile, your ferritin is below the fifth percentile. But that doesn't always equate with where you see physiologic effects, or what are called bioindicator effects. And in fact, with iron, you start to see the biologic effects just around the 25th percentile. Most of the literature centers on the ferritin of about 76, so about the 20th percentile, as to where you start seeing neurologic symptoms. All right, so the baby is born with a certain amount of iron, the preterm infant is, and then we do things to the baby. So on the left here, I've put in what are the things that make the iron balance more negative when they're in the NICU, and what are the things that make it positive. So if you are born with a low endowment, your IUGR, or you're extremely premature, you're more likely to go into negative iron balance, whereas if you're older gestation or you're appropriately grown, then you're more likely to be in positive iron balance. One of the biggest effects is phlebotomy losses. And this has really only become recognized by the work by Jack Widnes, who is a neonatologist at University of Iowa, who I had the pleasure of collaborating with for many years. And he pretty much coined or recoined the term, we call it anemia of prematurity. He calls it the anemia of phlebotomy. And he looked at the amount of blood that we take off these kids, and you can sometimes take the entire blood volume off in a 2-week period in a preterm infant by the amount of tests that we do. It's truly phenomenal. Now, of course, we transfuse the kids back, but you're always fighting essentially from below, right? I mean, we don't transfuse ahead of the game to say, well, let's transfuse them up so that we can bleed them down. We bleed them down first, and then we're always playing catch up. And you know that because the hemoglobins in the NICU are never, 15 or 16 like a newborn infant. They are down around, anywhere from 7 to 11. The American Academy of Pediatrics recommends starting iron at anywhere between 2 weeks and 2 months of age. Well, if you wait until 2 months, I'll show you the data in a couple of slides, you're going to have a very unacceptably high rate of iron deficiency in the follow-up period, something approaching 70%. So if you do that, you're at negative iron balance. If you start at 2 weeks, you have a better chance of being in positive iron balance. The AAP also recommends that iron be given in a dose range of 2 to 4 milligrams per kilo per day. 2 if you're a bigger, older gestation baby, 4 if you're less than 30 weeks gestation. If you then put those babies on EPO, on erythropoietin, and stimulate, instead of transfusing, you try and stimulate endogenous iron incorporation into red cells, you're going to increase the iron demand pretty dramatically. And again, because of the prioritization of iron to the red cells over the brain, that actually puts the brain at risk. And I'm going to show you in a couple minutes a mouse model of what that does to brain metabolism and outcomes. So if you are on EPO, you want to be at least 6 milligrams per kilo per day. So quite a bit above the recommended dosing. I think you're going to see more parenteral iron. The iron compounds that you can give parenterally are much safer these days, and we've seen this now in adults and in pregnant women. Sunny Jewell, who is a neonatologist works in this space at University of Washington, is prototyping some IV iron. And then finally, an odd thing, we want to see growth in our babies, right? But it turns out that rapid growth actually really stresses the iron axis. As you grow, obviously you have to increase your blood volume. As you increase your blood volume, there's a higher iron demand. So this is one of the few times where slow postnatal growth actually favors a certain nutrient status. This is a small literature, but there are developmental consequences of iron deficiency and iron supplementation in preterm infants. I talked to you about the Sanjeev Amin study. There it is. So slower central nerve conduction speeds on ABRs when the cord blood, or when the ferritin, actually as a measured ferritin, is less than 76, more abnormal reflexes in those kids. And then if you supplement preemies with iron, the earlier iron supplementation results in higher mental processing speed scores at 5 years of age. So there are these long-term effects. And Sunny Jewell's group has recently shown in the Peanut trial, which we were part of, and Raghu was the site PI, and Nancy Fahim was the site PI, I believe, up at North Memorial, that you get improved 2-year Bailey scores related to the cumulative dose of iron that you got during the Peanut trial. The Peanut trial is an interesting trial because it was giving EPO, high-dose EPO, to preemies for neuroprotection. There's a separate pathway by which EPO is thought to protect the brain through the JAK-STAT pathway. So high-dose EPO was given for neuroprotection. Of course, it stimulated erythropoiesis as well. And the iron dosing in the kids that were on this high-dose EPO approached 12 milligrams per kilo per day. Well, it turns out that if you plot the Bailey scores, either the cognitive component, the motor component, or the language component, as a function of cumulative iron, enteral iron intake, either by day 60 or by day 90, you see an increase in those scores with more iron that was delivered. And in particular, that worked in the placebo group, right? Because the EPO group, presumably much of that iron was going in to feed that red cell mass, keeps the hemoglobin higher, but was shortchanging the brain. So you actually had a better effect when that iron was given to the placebo group. So, and those of you who have rotated on the NICU know that we're constantly arguing about what's an acceptable hemoglobin, and mostly because of what Dr. Joe New calls necophobia, the fear that of necrotizing enterocolitis in general, and an association between red cell transfusions in the NICU and necrotizing enterocolitis. And that's also a huge topic, which we're not going to get into. But fundamentally, people, neonatologists, I think we're people, have gotten pretty scared of transfusing, and therefore just letting the hemoglobin drift down. You know, as long as the kid looks okay, what's wrong with a hemoglobin of 7? There have been several randomized trials, starting with a single site trial in Iowa, a Canadian consortium trial, and then the top trial that was just recently published in New England Journal, that showed that at least within the range of a couple of grams of hemoglobin between having a higher hemoglobin or a lower hemoglobin in the NICU, there really was not much of an advantage, at least on scales like the Bailey scales, kind of a general outcome scales. Animal models would suggest differently. Tate Gislin in our group has been studying phlebotomy-induced anemia. Here we can phlebotomize a mouse down at about postnatal day, starting at postnatal day 3, which is a brain equivalent of about a 26-weeker. We bleed them down to a target threshold of about 25% hematocrit. So think about that. That's a hemoglobin of 8. We see that on the unit all the time. And guess what it does to whole brain iron? It drops it by 40%. Again, because the iron that is being delivered to these mouse pups dietarily is going to try and replete that red cell mass. And let me just show you what that does to brain metabolism. So if you have low iron status and low cytochrome status, which Raghu has documented with very elegant magnetic resonance spectroscopy work, you have higher lactate levels, and you have a negative effect on neurotrophic factors like brain-derived neurotrophic factor or synaptic plasticity factors like PSD95. By the way, this Wallen here, that's Lori Wallen's daughter. She was a graduate student here. And so here's then you can say, well, how about you give them EPO? Maybe this is a hemoglobin effect. Well, indeed, if you measure something like VEGF, which is a pretty decent readout of hypoxic status of the brain, yes, phlebotomy-induced anemia. So anemia increases VEGF expression. So it's responding to hypoxia, reflecting the hypoxia, and you give them EPO and they have a higher hematocrit, and indeed that comes down. But if you look at something like transferrin receptor, which indexes iron deficiency, here's your brain iron deficiency with phlebotomy-induced anemia, giving EPO doesn't change it. And in fact, the lactate level in the hippocampus, which we think is a consequence of the hippocampal iron deficiency, increases. And the same thing happens in the cortex. So not good for your brain to be acidotic, I would say. And finally, after discharge, so now this will be relevant to those of you who are going into practice and inheriting some of these preemies. The post-discharge requirements of the graduate have not been thoroughly studied. There aren't a lot of studies out there, but you can either take a factorial approach, figure out how much iron they would likely need, or you can look at some of the observational studies. There are no randomized trials. So typical status at discharge. So let's remember we talked about how we can kind of get a we can figure out the full complement of iron that a neonate has by knowing the hemoglobin and knowing the ferritin. It accounts for about 88 to 90% of the total body iron. Think about your discharged preemie. Rather than weighing, let's say they go home around term, rather than weighing 3.5 kilograms, they're more likely to weigh somewhere around 2 to 2.5 kilos. We're getting better at this. But so that if you want to get that baby to 10 kilos at the end of the first year, remember you triple your term birth weight by a year, you'd actually have to quadruple or quintuple that weight. So again, you've got the stress of rapid growth and rapid blood volume expansion. That's going to increase your iron needs on a per kilo basis. And then we discharge our babies with hemoglobins typically between 7 and 11, rarely higher than that. And yet a term baby is born with a hemoglobin generally greater than 13. The babies go home with ferritins from deficient 30 to over 1,000, which would be overloaded probably from multiple transfusions, again, the average being 40. So there's a wide range of hemoglobin and ferritin due to, as I said, the anemia of phlebotomy, when and how you iron dose them, your transfusion practices. So it's very hard to predict a single standard dose for these kids going home and what you should be doing in the outpatient setting. And here's a tabular view of two different scenarios. Let's assume that the discharge weight is the same in both of these groups. One goes home with a hemoglobin of 13 versus another that goes home with a hemoglobin of 8.5. This would be the deficit in iron based on these two numbers. And one goes home with the the ferritin, which is normal, around 140, whereas the other one goes home with the ferritin down around the 5th percentile. So there's a deficit there too. The difference in dosing in the postnatal period is 2 per kilo versus 4 per kilo. And that would be for the entire first year, okay? There are observational studies to show that low iron dosing or delayed iron dosing or later onset of NICU iron supplementation is associated with unacceptably high rates of iron deficiency. I told you that almost 70% rate if you delay iron intake until 2 months of age. And a Cochrane review, so there's 26 studies looking at over 2,700 infants, suggests that about 2 to 3 milligrams per kilo per day was where you wanted to land in that postnatal period. Now that compares to term formula that gives about 1 per kilo per day. And there's certainly a lot of controversy in terms of term breastfed babies, whether they need any iron supplementation at all. That's of course because they're fully loaded. So how much iron would you supplement in those kids going home? And the answer would be around 2 to 3 milligrams per kilo per day. And then kids that you all are going to take care of pretty frequently are the late preterms and SGA. So these are the kids in the group of about that range from 2,000 to 2,500 grams, either because they're slightly early or because they're IUGR. And they're a bit of a forgotten group because they're all usually in the normal newborn nursery and perceived as healthy. But the fact is that that group has an increased risk of behavioral problems. Magnus Damalov is a neonatologist in Sweden who did his graduate student did a very elegant study where, everybody breastfeeds there, and they randomized kids to either get iron supplementation or not for 6 months. And the range of supplementation was either 1 or 2 milligrams per kilo per day. I want to show you what the rates of iron deficiency were at 6 months and then the behavioral outcomes. So if you were late preterm, breastfed, and did not get any iron supplementation, your rate of iron deficiency was 36% at 6 months and 10% anemia rates. And you can see the dose response with increasing amounts of iron to drive that rate down to 0. When we looked at the behavioral outcomes, and this is at 3 years, but they've documented now out at 7 years, the kids who got either one of the 2 supplementations had less problems on the Achenbach child behavioral checklist, whereas the kids who got no supplementation, breastfed with no supplementation late preterms, had problems with emotional reactivity and attentional problems, which interestingly lies very nicely in the biology of iron. So let's wrap this up then with the dosing. I hesitated to put anything on this first bullet because we're not supposed to be formula feeding babies. Those who are, just by matter of fact of how much we supplement iron in term formulas, will get about 1 milligram per kilo per day. Breastfed babies, of course, get much less. If you are in that 2,000 to 2,500 gram group I just showed you, the recommendation is 2 milligrams per kilo per day. If you were a preemie and less than 2,000 at the time of less than 2,000 grams birth weight, for discharge, you're going to be looking at 2 to 3 milligrams per kilo per day. If you document a low ferritin level, which we do monitor in the unit, we typically increase the dose by 1 to 2 milligrams per kilo per day. It means that you are using your bank account, if you will, you're using your storage. That tells you that you have inadequate dietary intake. So you up the dietary intake. I talked to you about when you're on EPO, that you get 6 per kilo per day and go up if the ferritin is dropping. If you have a high ferritin from multiple transfusions or inflammation, we typically discontinue the iron supplement. And so, sorry, this is activated, but if you look at iron monitoring of iron status, of course, during transition, the first 10 days, we're not really looking at iron status. We're looking mostly at hemoglobin, but we should be keeping track of what's happening to that hemoglobin. I'm also advocating that we get a ferritin on kids at birth. It's a good thing to know where you're starting from. During our preemie growth phase in our NICU, we follow hemoglobin and retic count. You get low retic count, and we'll be following reticulocyte hemoglobin percentage in the future, and ferritins to see whether you are tapping essentially into your storage pools and therefore need more iron. And then post-discharge, I think the main point here is that you want to look at the iron status at 4 weeks and 6 months, not wait until the AAP recommendation of 12 months. Where's the field going? I think you're going to see a reduction in formula iron content for term kids. That has to do with this final point down here about enteral iron and intestinal microbiome dysbiosis. So in Africa, and now there's a study in the US too, it shows the concern is that unabsorbed iron with high dose iron supplementation feeds siderophilic bacteria, including E. coli and Salmonella, and that's a risk to their intestinal health. The question is whether there's a risk for necrotizing enterocolitis in preterm infants, and there's a couple studies that are ongoing to try and address that question. So I'm going to stop here. I hope I've shown you that iron plays an important role in neurodevelopment, that it's regulated within a narrow range. We don't know how well prematures can actually regulate their iron uptake. Deficiency presents a risk to that developing brain, and iron overload needs to be thought about and looked at more. That post-discharge preterm is especially at high risk for iron deficiency, especially if they're growing rapidly and left with a low hemoglobin and ferritin. And we need to learn more about this shift in the gut microbiome after enteral iron supplementation. And as I always tell people, I don't actually do this. When I walk into the lab, they look at me and they go, "You're not going to touch anything, are you here?" The answer is no, I don't touch anything, but I can analyze data occasionally. But you can see this long list of people that have worked on this problem for many years in our lab, and then our funding sources and our major collaborators. So I'm going to stop here, and hopefully we have time for at least a couple questions.
Thank you, Michael. That was fantastic. I'll start out with a question, since you kind of teased it during your talk about the microbiome and a little more about the microbiome. In the peanut study, or maybe other studies like it that have used high dose iron supplementation, have there been any gut outcomes that have popped out as potentially problematic?
Right. Yeah, good question. So both in the peanut trial, which was published this year, and the top trial published last year, there was no effect on rates of necrotizing enterocolitis. But NEC's a pretty rare event, and the studies weren't powered properly to look at that question. Animal models, like one that Akil Meshwari has done and Sean Stoll have done, show that anemia for sure causes more intestinal inflammation. Whether that has to do with iron status, we don't know. And Tina Ho, who is a budding young neonatal researcher down at University of South Florida, has shown a relationship between iron supplementation and intestinal microbiome dysbiosis, if you will, in preterm infants. Again, not powered enough to know whether it's affected the rates of NEC or not, but just to show the dysbiosis.
All right, we've got 3 questions. Let's see if we can do 3 in 90 seconds.
We can do it.
This is from Andy Rzepka, one of our community pediatricians. When do you recommend getting labs on late preterm infants?
I am assuming he means in the outpatient setting.
Yes, that is where Dr. Rzepka and I work, in the outpatient setting.
6 months of age.
6 months. Okay, great. Any concerns about preterm infants tolerating enteral iron? How do you balance giving them enough iron with any intestinal intolerance of the supplement?
Yeah, so that's 2 parts to that question. Babies in general do not show intolerance to iron. That's, at least term babies don't. That's been done by blinded studies where, these are long ago, people covered the labels so that parents didn't know. And kind of an anecdote was that when they supplemented the soy formulas, or when they announced on the label that they were supplementing the soy formulas with iron, they had always supplemented them, but now they had to put it on the label. All of a sudden, parents called in and said, "My kid's got all these problems," and the fact of the matter was, it had always been supplemented. So that's been put to rest. It appears not to do that. Preterm infants, I don't think that's really been looked at very carefully. And again, this idea that any unabsorbed iron, both because they don't regulate iron uptake perhaps very well and more goes downstream, and also the high doses we're using, if it did cause intestinal dysbiosis, again, that needs to be shown, you could imagine how there might be distress with that.
Great. Okay, last one comes from Brad Miller in endocrinology. You talked quite a bit about weight growth. What about associations with iron deficiency and catch-up growth in length and head circumference for infants who are IUGR or SGA?
Yeah, thank you, Brad. That's a great question. So again, that U-shaped risk curve that I showed, there's a literature both on excessive iron supplementation retarding linear growth, and also iron deficiency retarding linear growth. So again, it's that sweet spot of maintaining sufficiency. And the definition of sufficiency, which is what Ragu studies, is what's really important here. How do we know when we're in that sweet spot? What are the biomarkers that we use? And currently, the WHO and AAP have been advocating hemoglobin alone. The WHO has just recently changed to say we really probably should be adding ferritin. As most of you know, ferritin is also an acute phase reactant, and kids do get infected. So you have to be a little careful how you interpret it. But we do want to know that whatever the hematologic status is driven by the iron, not other reasons for either anemia or polycythemia. So yes, both iron underload and iron overload will retard linear growth. And I think Brad's point here is that linear growth is, as you know from Sarah Rammel's work, linear growth reflects brain growth.
That was well done. Slightly over 90 seconds, but
Sorry,
three
the
huge
last one,
topics.
well, I expected a complicated question from Dr. Miller. That's fine.
All right. Thank you so much for an excellent talk.